Top Med Talk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. We are coming to you live from the American Association of Nurse Anesthetists 2019 Annual Congress in Chicago, Illinois. AANA 2019 is a gathering of over 3,000 certified registered nurse anesthetists, or CRNAs, for the largest networking and educational event in nurse anesthesia. Now, this year, the AANA has partnered with Top Med Talk to bring the meeting to our listeners. Over the course of 3 days, we'll be sitting down with presenters, AANA leadership, and delegates to discuss hot topics in the CRNA community and anesthesia practice. Now, I'm joined by my co-host, editor-in-chief, Monty Mythen. Hello, Monty. How are you?
Hey, Desiree. Good. Great to be. I really enjoyed that session you just did.
Yeah.
Enhanced recovery nuts and bolts.
Yeah. Well, you got to break it down.
Yeah, but still on 1.0.
I think
Is that
so.
right? Yeah, there was a good crowd there.
It was a good crowd, and I do this all the time now. So when I first started when we were first starting the presentation, I asked everybody who's doing enhanced recovery, and probably 3/4 of the room raised their hand. And then when we got to talking about the actual continuum of care and enhanced recovery from pre-op all the way through, I asked again who was doing that, and no one raised their hand.
So you see some people there sort of thinking, I don't really understand the question.
Yeah.
Yeah. That's nothing against those individuals, but we're talking about things that are enhanced recovery 3.0, 4.0 now. We have to remember the fact that most people haven't got started yet.
Yeah, I totally agree. Right. So I think it was good. We kind of broke it down and I think set it up for further questions later today in some of our other sessions. So it's going to be good. Yeah. So we were able to catch up. One of the things that we love to do at meetings is not only talk to presenters and key opinion leaders, but it's also talking to delegates and students. And so we had an opportunity to catch up with a couple students. Monty, you caught them?
Yeah, so yesterday in the trade exhibition we met Jaclyn and Stephan, who came over and enthusiastically engaged in some conversation. We noticed they're from Durham, so therefore think, there's a clue. They're both from Durham, both speaking as students, so that's really interesting. Yeah. So I guess from Durham, they're probably from Duke, was my guess. And as I'm an adjunct professor at Duke and used to be on faculty there, we thought we'd probe a little bit further. Yeah. And obviously they're at Duke, they turned out to be world-class people doing fantastic research.
There you go.
And that's what we're going to hear about. So Jaclyn, tell us who you are, give us your full name and what you're up to.
All right, my name is Jaclyn Migliarese. I'm a local here in Chicago, so it's good to be back home. I live in Durham currently, going to Duke, starting my third year in nurse anesthesia school and hoping to graduate in 1 year from now.
And you're saying that before that you were in pediatrics, was it?
Yes, I worked here at Lurie Children's Hospital for 3 years in the pediatric intensive care unit. So shout out to Lurie Children's. It's an amazing hospital.
And there's only one answer to this question. How's the training and education going at Duke University?
I mean, that's why I moved across the country for it, and it has definitely met my expectations and probably exceeded them. So excellent. The faculty's been excellent, and our clinical sites have been amazing, so I've really enjoyed it.
Right answer. Stephan, tell us about yourself.
I'm Stephan Bodnar. I was originally from Michigan and kind of worked in several different hospitals there. I did surgical ICU, medical ICU before I went back to school at Duke. Duke has been an amazing place to not only learn, but just the opportunity for research and just my overall training. I'm hoping in the next year to graduate as well. I'm going into my third year and see what comes in the future.
So how'd you end up speaking here?
Yeah.
Well, Jaclyn, I think it was, about a year ago?
I think almost exactly, yeah.
That we got involved in a project that was brought forth by a couple of people at Duke University Hospital, and they wanted to look at the best way to ventilate patients during the intraoperative period. And that got started looking into lung protective ventilation. And we were 2 of 6 researchers that were involved in the literature review and ended up participating in a consensus meeting to write guidelines. And when we were at the conference a year ago, I was sitting in the audience and thought this would be something we really need to present. And here I am today.
So who were some of the physicians from Duke involved in the consensus guidelines?
The physician and president for the consensus meeting was Chris Young.
Yeah. Who's an intensivist at Duke?
Yes, he's an intensivist and anesthesia as well.
Did he tell you about his trip to Everest?
No, I don't think he did.
Oh, yeah, I don't think he told either of us.
Ask him about that.
I'm going to have to ask him because I don't think I've ever heard that story.
And who else was on the consensus? Well, it's been published, hasn't it? The consensus guideline?
Not quite. We just got accepted for publication in the British Journal of Anesthesia. So excellent. I think it should be coming out very shortly. Went through a few drafts and like I said, we're accepted and excited for it.
So were you stalking Monty? So you're saying Duke?
They didn't have a clue I was. They can look me up later.
Actually, when he introduced himself and he told me he was on faculty at Duke, I went, I should probably know who you are.
Adjunct.
Yeah.
Adjunct is code for not paid. So that's what adjunct is. But it's wonderful to be there, wonderful to be back. It's a great institution. And the guidelines, I think, are about post-operative pulmonary dysfunction, perioperative pulmonary dysfunction, lung protective strategies, etc.
So it kind of encompasses the whole perioperative period, but the reason it got started is because you have these high incidences of post-operative pulmonary complications. And so the thought in anesthesia is that, we've been ventilating this way, patients turn out to be fine, and then we have these high complication rates. It's actually the second highest post-operative complication, second to surgical site infections. So, we have this high incidence, and there's guidelines for almost everything in anesthesia, but somehow ventilation, which is maybe the most important part of our job, and there's no guidelines out there. So there's been people here, like at Duke specifically, that were spearheading, there's a lot of research out there. It just hasn't been, disseminated. Yeah, collectively looked at. It hasn't been disseminated. So Erica Harris, who's a CRNA at Duke University Hospital, really spearheaded this and got Chris Young on board, and then paired with GE, and then Stephan and I got brought on board afterward. So
as you say, post-operative pulmonary complications are very common. We don't often see them, because we wake people up, extubate them, and say, well, they were breathing fine in recovery, bye. But as you say, it's the second commonest. And when it happens, it's then associated with subsequent bad things that happen. You're more likely to be in hospital for a long time. Yeah. You're much more likely to die, very sadly, if you get.
Yes.
Usually you don't, but you're much more likely to. It's bad stuff.
So looking at specific to thoracic and abdominal type procedures, it's actually, the incidence is much higher than that. It's actually almost like 30% of patients will develop it. And what's the scariest part is that 20% of that patient population that develops postoperative pulmonary complications, they actually end up dying because of it. So I think we don't see that side of it, so we don't realize that what we are doing can actually affect that patient in that way.
So I work mainly on surgical intensive care. That's where I met Dr. Youngs in the past. We worked together in the past, myself and Chris. So if you do surgical intensive care, you kind of think everyone gets it.
Yeah. Everything you see is
As they come back in through the door, you think, damn, no one can breathe out there. So we have a slightly different view of
perspective.
it.
Yeah.
So the guidelines here are more about protective lung ventilation strategies as opposed to preparation beforehand or treatment after you develop the problems, or everything?
Yeah, I do. Go ahead, Stephan.
I was going to say, there's a little, they focus more on the intraoperative period, I would say, overall.
Yeah, I would agree with that.
Yeah.
But there is, at the very beginning, we looked at the preoperative optimization and just talking about how there's different risk factors that can set you up to develop these complications postoperatively. And if we maximize and optimize our patients beforehand, then we can help reduce that as well.
So there are various different lung-specific scores now, aren't they? Pulmonary risk scores that are in play.
Absolutely.
But any sort of risk score you look at, the higher up the risk scale you are, the more likely you are to get pulmonary complications.
Right. And one of the recommendations says, so there is no one score. I know the Aristocat and Las Vegas scores are popular. It's not so much about which score you use, as long as you're using a somewhat objective measure to say how much risk, what is the relative risk for this patient who's in front of me. And I think right now, while, you see heart failure or other things and you're like, okay, well, they might have a pulmonary issue, it's really making it more objective than a subjective thing. And that way we can risk stratify our patients and know who we need to optimize maybe even more before surgery.
And I think we're not crystal clear, but based on a number of interviews we've done on Top Med Talk with experts, there are certain things you can do beforehand. There's a sort of holistic things, get fitter, get better, live a better life. But there's also muscle, inspiratory muscle training, things like that, sort of ICOF type of regimen that's been talked about. But we're going to concentrate mainly for this interview, because we know a lot about that, about the in the OR bit. And that's the protective lung ventilation strategies, or however you want to term it. Stephan, where did you go with that in the guidelines?
So the beginning of that started with looking at tidal volumes, PEEP, and then recruitment maneuver utilization. So those are kind of the big three things about lung protective ventilation. And many providers, they've been taught, use higher tidal volumes, 10 or more, to help keep alveoli open during a case. Looking at the lung protective literature, it's more 6 to 8 mLs per kilo, and helping to maintain that tidal volume that we normally breathe.
Because we're not pulling much at the moment. Most of us, we can barely see our chests moving. It's
correct.
And then just to make a note, it is ideal body weight, not total. Yeah. So for people, we have a high obese population, just to make sure that 6 to 8 mLs per kilo is ideal body weight, and not total.
Do you estimate that by height or forearm length or the ideal body weight? How do you do that practically, locally?
There's a lot of equations out there. There's a few different ones, but most of them have to do with based on their height.
Height's pretty good.
Yes, it's a good estimate.
And then, I'm pretty sure everyone I've seen has been with height, if I remember, from what we've been using in that area. For the PEEP, the guidelines state to start at 5, because looking at different literature, there's usually either a PEEP of 0 or a PEEP of 5. Mm-hmm. And what you'll notice is when you don't use any, you get this progressive collapse in the lungs, and that leads to more complications. I think the 5 also comes from, I've been in a lot of places where our ventilators, that's what the default is.
Yeah.
So is it 0 and 5 because those are the defaults, or because that's what people are setting? Some of the literature that's out there says 5 may not be enough for the majority of people, and you might need a little bit more. There's a couple articles out there that show as you move up to 7 or even 9, you get better ventilation, more homogeneous ventilation throughout the lungs. So while the guidelines do, I know, state 5, it also talks about individualizing that PEEP. So making sure you're utilizing whatever the patient needs, you're getting the best compliance for their lungs and allowing them to ventilate optimally.
And does the paper go into PEEP challenges and how to do that? Mm-hmm. Does it?
It does. I think some of it got cut out due to length.
Yes.
But I wish it didn't, only because I think PEEP overall is probably one of the more controversial topics in all of lung protective ventilation, because some people across the world have been using no PEEP, and to tell them then that they should be using 9 is a really drastic change. So part of the reason, we came up with the recommendations and the expert panel decided to land on 5, even though a PEEP of 5 has been actually shown to be largely insufficient in almost any of the literature that compares it to PEEPs that are higher. They chose it because we don't want to make change too drastic. We want people to realize that some PEEP at least is better than no PEEP. And, with all change, there needs to be, sometimes it has to be done in small increments. So
if you get everyone to 5, then hopefully the next stage would be to customize.
And
exactly.
That's exactly it. The next time we revise these guidelines, I'm sure that could move up some more. And it would be also very helpful if we have some better literature out there that is supportive of where maybe we need to move to.
And the good thing about 5 is if everything defaults to 5 and nobody notices, you probably won't notice a hemodynamic change in the patient. It can be snuck in.
Yep.
And you're not going to say, oh man, who's messing with my patient? And
exactly.
PEEP.
And what's some of the most interesting things we read about was, yes, the big worry about using PEEP or more than 5 or higher PEEPs is that blood pressure change or hemodynamics. But if you optimize it and individualize it, you don't see that. So if you overuse PEEP and maybe say, let's be drastic, and you see those changes, well, that patient probably didn't need to be that high.
Because if you knock the hemodynamics, you'll knock the VQ matching in the lungs, and therefore you'll knock the variables that you're judging that demonstrate improvement. So it should all work.
Yeah, exactly. And I think people are worried about PEEP in terms of impeding venous return and, like I said, impacting your blood pressure therefore. So what's interesting is that a lot of the literature, showed that while there was very minor hemodynamic impairment, maybe during a recruitment maneuver, it was very temporary changes in blood pressure done because of all that high pressure. But really, if you're keeping an open lung, you're actually you're decreasing shunt, improving VQ mismatch, and you really should be optimizing your patient. And again, like Stephan said, you can potentially put PEEP too high, but like I said, that's where you have to optimize it. And really, it requires us to be active participants in ventilation. I think a lot of people nowadays are setting the ventilator, turning it on, and just letting it be as long as the sats stay relatively fine. And they're honestly hiding a lot of bad ventilation by using high FiO2s with that.
Yeah, you've got to get back to filling in your electronic health record.
That's right. Yes, that's exactly. Very, very true.
So before I hand over to Desiree for some very practical questions, the recruitment maneuver, did you say yes or no to recruitment maneuvers?
So, yes to recruitment maneuvers.
Just remind everyone what a recruitment maneuver is.
Yep. I'll say, so recruitment maneuvers are just a utilization of pressure. It could be a very large one tidal volume breath that is held for a period of time, or multiple cycling maneuver breaths that are larger tidal volume to reopen the lungs. And
that's sort of what we do normally, isn't it?
It is.
Physiologically, we sigh,
Yep.
or we deep breathe, or we deep breathe and cough as a normal part of breathing.
Yes.
Yep.
So that we, in our ventilation, want to mimic that. And we said yes to recruitment maneuvers, but only when they're needed. So there's been some literature out there that's looked at it every 30 minutes or not at all. And that didn't show a very big change. But when you had a patient who did have some of that alveolar collapse and then use a recruitment maneuver, that was found to be beneficial. The one thing that we did talk about, and there was consensus on, was a lot of times you'll, in anesthesia, flip them off the vent and use a bag squeezing technique to give them a breath, hold it, and then flip them back on. So the guidelines go into advising against that. And the reason for that is a lot of providers will squeeze the bag, let go, and then flip them on a vent. So when you have that happen, you have this period of time where everything that you recruited is going to start to recollapse because you don't have any pressure in the system to maintain that pressure. So the one thing was to use ventilator-driven alveolar recruitment maneuvers if possible.
And that's, again, if people aren't familiar with it, you can look that up. There's plenty of stuff online. It may or may not be in the paper. Is it in the paper how to do recruitment?
They detail it actually pretty well.
Okay.
Yep.
Yeah, and they talk through all three different types of maneuvers
Awesome.
and how they're usually done.
So Chris is the first author. Is it Youngs, C. et al., British Journal of Anesthesia in Press? Is that the
Should
paper?
be.
It should be.
And the title, broadly speaking, roughly is pulmonary.
It's lung. I think it's lung. Consensus meeting on lung protective ventilation.
Perfect.
Let me look it up real quick, and I can tell you.
Look at perfect.
Well,
We'll get it. We'll get a hint in the show notes about it.
Yeah.
We can see if we can find
Yeah,
it.
it's changed a couple times over the past few weeks. So.
Sure.
You never know until they get the final
Yeah.
version
Exactly.
of it. There we go. That's a good get out of jail free. Desiree, some practical questions.
Yeah, I was just going to ask. So, being a CRNA, what can I take home tomorrow and kind of change in my practice to utilize lung protective ventilation?
I think, as I mentioned earlier, being a more active participant and, like I said, looking at your patient. And I think a lot of things need to be based somewhat, like, again, on a patient's BMI and optimizing, because patients who are bigger are going to need more attention, and also people who are older, less healthy lungs, all those people are going to need more attention. I think the big thing is to think about normal physiology. And I think if you think about how the lungs work, when we take away patients' chest wall tone by giving them paralysis, they're not going to be able to keep their lungs open as well just because of the things that we've done in anesthesia to them. So going in the supine position, induction drugs, paralyzation, loss of chest wall tone. So it's saying, what do I need to do to make up for those factors that we took away and to help keep those lungs open?
Yeah.
I think a good start is, I think almost all the literature across the board said 6 to 8 mLs per kilo ideal body weight. Was, I think, shown to be beneficial across the board. But with that said, if you're using low tidal volumes, you do need to have an adequate PEEP to also keep those alveoli open and to maintain a positive pressure even through the expiratory phase.
Yeah. And so, my ventilator at home, it's kind of older. So, we can't do a lot of adjustments. Are there new, ventilators that are kind of coming out that have recruitment maneuvers built in? Are people utilizing those things? Did you all look at that?
Yeah, it's wonderful. I mean, we have used some of the newer GE vents at Duke, and they have these really nice screens. And in the procedures section, there's actually a few different things you could do. A lot of them have the vital capacity maneuver. And as Stephan was saying, bag squeezing techniques for recruitment are bad because people lose that pressure. But you can do vital capacities right through the vent and set the pressure you want and the exit PEEP that you want. And so you could do it right through the vent. The one thing with that is you need to turn up your flows if you're going to do it. Otherwise, the bellows will drop and it'll alarm at you. Gotcha. Otherwise, the newest vents at Duke University Hospital also have pressure cycling maneuvers right on the vent. And they are incredible. You can actually watch when your patient opens. So if you do this pressure cycling maneuver on the vent, and that'll automatically make all those inspiratory pressure and PEEP adjustments for you in a stepwise increment, you can actually watch, if you're looking at your compliance, when the patient's lungs open up, and that's a good way to tell about where your PEEP should be.
That's really cool.
I was going to say, and I can add something to that as well, is say you have a ventilator that doesn't have those maneuvers on it, you can do them yourself. You can do them with either a volume control or a pressure control mode. In the volume control mode, all you have to do is slowly increase your tidal volume to reopen those lungs, and what you're looking for is your targeted plateau pressure. And once you achieve that, give 3 to 6 breaths, and then set your desired PEEP, and you'll be able to bring your tidal volumes back down to that lung protective 6 to 8. If you're in a pressure control mode, what you could do is, and I had read an article about this, was change your inspiratory pressure to 20, and then you can step your PEEP up and slowly, I think it's every 4 breaths, increase your PEEP by 2 until their lungs are reopened. And once you're there, bring your pressure back down so you have that 6 to 8 ml per kilo tidal volume, and then step your PEEP back down to where you want it to end at. So you can actually perform those recruitment maneuvers on your own, even if you don't have the presets in the vent.
Yeah, and I was going to say, I think that's a really great point, because I know people across the world are using different types of ventilators, some older, some newer, and you could do all these things on your own. Obviously, if it's preset, that's nice for all of us. But the big thing is, especially with recruitment, is that if you're going to recruit, that means you needed more PEEP. So anytime you recruit, you should be adding probably around 2 of PEEP at least, and see where your patient goes from there.
So sorry if we've missed it already, but when are you, or did you speak?
Actually speaking this afternoon.
Fantastic. What time?
4 o'clock today.
4 o'clock. Let's see if we can get out this before 4 o'clock. a big shout out. Congratulations to you. Congratulations to Dr. Chris Youngs and everyone who did this work at Duke University Medical Center. As always in Top Mid Talk, we have to say there are other universities available.
We understand. And I think we would also just like to thank Dr. Charles Vacchiano. He's who got us involved in this.
Brilliant.
So.
Great.
And the whole team at Duke. Well done. Thank you very much indeed. Congratulations. If you want to, please do follow us on Top Mid Talk. You can find us at topmedtalk.com. The easiest route in is probably the website. When you get in there, if you click on one of the buttons like our fantastic app, which has a great search engine, you click on that, it will be asked to subscribe. When you subscribe, not only will you get regular updates, but we'll send you a podcast every day of the week. We've got 700 in our back catalogue. It's free, real free, open access medical education. You can also find us on social media. Desiree.
Twitter, Facebook, LinkedIn.
and Instagram.
Oh my gosh. This is why we're actually not on Instagram. We have some pics up on Instagram.
We'll work on it.
But we're working on it. Yeah.
Great. Thanks, everyone. Well done.
Thank you so much for having us. We really appreciate it, and we're excited to talk today, so I hope everyone comes by.
Thank you very much for having us.
Keep listening to Top Mid Talk.
There you go. All right. Cheers. Thanks for listening.
Top Mid Talk.
Migliarese here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.